Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
This is the first of a two-part episode on burnout in oncology. Stay tuned for part 2 of this conversation, launching June 30th, 2021.
Hello, and welcome to ASCO's podcast episode focused on burnout in oncology. The prevalence of burnout among oncologists and other healthcare providers that care for oncology patients has been increasing in recent years, bringing along serious implications for personal well-being and professional satisfaction. My name is Todd Pickard. I'm an oncology PA at the University of Texas MD Anderson Cancer Center. I'm pleased to introduce our 3 guest speakers today. Dr. Faye Huckabee is a clinical health psychologist and research ethicist at the University of Chicago Medicine. She's also co-chair of the ASCO Oncology Clinician Wellbeing Task Force and has extensive research experience in burnout. We're also joined by Dr. Daniel McFarland, a medical oncologist and consult liaison psychiatrist specializing in head and neck thoracic malignancies and psycho-oncology at Northwell Health Lenox Hill Hospital. He has conducted research on empathy, resilience, and distress in trainees, and edited an upcoming Springer book publication entitled Depression, Burnout, and Suicide in Physicians. And finally, we are also joined by Dr. Seya Levasani, a medical oncologist specializing in breast cancer and an assistant clinical professor in the Department of Medical Oncology and Therapeutic Research at City of Hope. Many oncologists around the world are struggling with burnout, but the topic is rarely openly discussed. We are excited to launch a discussion of causes and signs of burnout, as well as proven tools for the prevention of burnout that our listeners may apply in their own daily lives. Welcome all. I look forward to this interesting conversation today. Dr. Levasani, can you tell us about your personal experience with burnout during your training and professional life? And then how has the pandemic affected your experience of burnout?
Sure. First, I want to thank you for having me on this podcast. I noticed the symptoms of burnout when I was an internal medicine resident and had to do 30-hour shifts covering the ER, admissions to internal medicine service, code blues in hospital, etc. It was a challenging time. I had a young child and calls were brutal. I would try to relax and meditate, and the peer support at that time was critical. All residents were very close to each other, which I believe can be the best strategy to overcome burnout during training. When I was going through my fellowship, things were definitely better, and my calls were all home calls. And then I started to work as an attending. Initially, I was under the impression that things would be easier, but I realized that my job is still very stressful, but in different ways. I'm fully responsible for my patients and treatment decisions I make for them. Patients and their families are under tremendous amount of stress. We need to provide them with support and give them strength to help them to go through treatment. I felt multiple times that this is overwhelming for my health and well-being. I experienced burnout as a medical oncologist when I was in the process of moving to my current position, which required moving from East Coast to West Coast. Moving and settling in were very stressful. And then this month actually marked the 1-year anniversary of the start of the COVID-19 pandemic and the subsequent restrictions and lockdowns. It was an exhausting and challenging year for everyone, especially the healthcare community. Having countless number of meetings, integrating telehealth into our practices, fear of contracting COVID and spreading it to our families. When I look back at this past year, I have experienced fear, disappointment, but at the same time, resilience and hope. I feel like I learned a lot. We learned how to fight a pandemic. I personally learned to appreciate my health and time with family. I learned how to use small things during my day to cope with the stress better. This has been my experience so far.
Thank you for sharing that. COVID-19 has definitely added to the stress and burnout that many of us face. So thank you. It's a very common experience for many of us. Dr. McFarland, would you like to share your personal experience with burnout? And has your approach to preventing or dealing with burnout changed over the course of your career? And if so, what's working well for you?
Yes, thank you very much. I am delighted and honored to be here with everyone today and to share my story and our mutual interest in burnout and hopefully help some people along the way. Being that I had trained in two disciplines, medicine and psychiatry, I became very interested in burnout mostly as a result of having undergone supervision in psychiatry, and then similarly to what Dr. Lavasani was saying, seeing the intense training conditions of the residents actually once I had become a fellow, and it made me think back to a lot of the principles that I had learned undergoing supervision in psychiatry, meeting with the psychoanalyst. At that time, I was in Chicago. Go down to Michigan Avenue and have these talks all about me, what my experience was in dealing with patients and life and the things that, would trigger emotion for me and et cetera. And I really just felt like I just wish everyone could have that experience. And it almost made me sad or angry that people didn't. And because once I became a fellow, I saw that the residents actually were dealing with the sickest patients on the wards, talking to families, breaking bad news, and just the look in their eyes, right? And I maybe my residency was rather cushy. I don't know. It was a little bit more intense where I trained for oncology fellowship. So I had started a program of research there to kind of look at the empathy of resilience and distress. And, I think stemming from that, I got interested in burnout because there are these kind of conceptual ideas that are all kind of overlapping. And for me, it started from this idea of how does the patient environment affect the clinician. And thankfully, we're at a point where you said at the beginning that we're not talking about burnout, but we are talking about burnout. We're talking about it right now. And the conversations are ongoing, are increasing, becoming more nuanced and depth. And it's actually a really exciting time. And, not that long ago, this was kind of off limits to really explore this area. And I think it's exciting. And I think there's definitely hope. In my research, and I've mentioned this book that we have coming out, et cetera, when you look back, these things are not new in a sense, right? Like there's always been this kind of underbelly of medicine, and the stoicism that was pretty much the only kind of working way to move through it, like, sort of put up or shut up, frankly, which didn't work for a lot of people, right? And now we have an opportunity to make it better. And so it's so exciting. So, in terms of answering your question, it was really at the beginning kind of an academic interest, I suppose. On a personal level, I will tell you that many of the things that you read about with burnout, I've certainly experienced seeing in practice, seeing a lot of patients, that feeling of kind of cynicism. This isn't working, losing the motivation, this is somehow losing the meaning, which is distressing, right? Certainly cases of moral distress are challenging. and you can bring it home. And even as a psychiatrist, where you're sort of trained not to do that. It happens, and we see things in oncology that they don't see as much in psychiatry. So how do you figure that out? With the help of our palliative care colleagues, et cetera, is really important. I noticed when I started practicing, for example, and it was a very busy practice at first, that I would use humor in a way that wasn't normal for me. I'm a somewhat funny guy, I suppose, but it was a little too much, and I knew that. And one day I sat down and I said, this isn't me. Nothing atrocious had happened. I don't know, maybe I turned someone off, I don't know. But it was just this little light bulb in my head, like something is different. And I'm just thought, okay, of course. I mean, I'm the attending now. I'm seeing, these are my decisions. This is weighty, heavy stuff. A lot of patients are not doing well. Many patients were doing well, which is great, but you see what I'm saying. So, wow, it happens, right? It happens to all of us. And yeah, that was kind of the biggest thing. The other thing, having sort of different disparate interests has been challenging. That a lot of what burnout stems from are systemic issues, our personal issues. How do we interculate ourselves into the systems in which we work? Having interest in medicine and psychiatry, that's not easy. And so, I've had to step back, reflect, take some life changes here and there, which I think for the most part has actually been quite beneficial. So you asked kind of, what are the things that I'm doing to help with burnout? Those are a couple. I would say the last thing, we're always told to eat well, do yoga, exercise. I do feel like I understand why we need to do that a little bit more. And that's what's helpful about learning about burnout, because some of these things, you get burnt out learning about all the things you're supposed to do for burnout. But if you understand the reasons why, and we'll probably talk about the data a little bit later, it's really helpful. So I'd say like a new approach to my personal burnout prevention regimen.
I agree. I am encouraged by the fact that we're having more of these conversations, and our training is really an intense time. I wish 25 years ago, when I went through my training, that it was encouraged to talk about burnout, because back then it was not. So you simply just suffered in silence, put up, shut up, keep coming, and do what needs to be done. So I'm very encouraged and grateful that we're having this conversation. We've talked a lot about burnout, but Dr. Hlebaki, how is burnout defined? I mean, many people, we all think what it is, but help us. What is it? What's the definition?
Oh, thank you. It's such an honor and a pleasure to be with my esteemed panelists here, and especially with all of you ASCO members to talk about your well-being. That is our priority at ASCO. So burnout actually is an empirically driven phenomenon, and it's been formally defined recently by the World Health Organization as an occupationally related syndrome that results from chronic workplace stress that hasn't been successfully managed. And there are three dimensions or three signs that are apparent. It's a feeling of physical and emotional exhaustion. It's a feeling of cynicism and pessimism, and a decrease in professional efficacy. The clinician feels like they're just not as efficient as they should be. Now, this is the hardworking physician. It actually starts with several stages, and Herbert Freudenberger, the phenomenon is actually not new. It was first described by Herbert Freudenberger, a psychologist in the 1970s, who noticed his colleagues on the inpatient mental health wards going through this phenomenon, this state of exhaustion and cynicism and reduced professional fulfillment and efficacy. And it's been then well described now in the research by industrial organizational psychologists like Christina Maslow, and more formally driven with empirical research and instruments that have been developed. And then now in the clinical setting, and specifically oncology, we have a lot to thank Dr. Tate Shannenfeld, because he was probably one of the first ones to really describe it in oncology and oncology physicians as to what. So it certainly is not new. It's not just a bad day. It's not just being stressed out. This is a chronic, insidious process that we really have to prepare clinicians for, whether they're junior clinicians, to say this is going to happen, to be prepared for it. And I really appreciate Dr. McFarland's talk about, psychiatry and psychology. We are almost a little bit more prepared for that. I think a lot of our supervisors tell us, you better watch out. You're going to be dealing with a lot of sick patients that are undergoing a great deal of suffering. Both he and I are in psycho-oncology, so we work with the cancer patient and the mental health aspect as well. So there was always this kind of supervision, making sure that you were okay. And unfortunately, I think the COVID pandemic has afforded us an opportunity to have an open discussion, to reduce the stigma around burnout, that this is simply okay. It is right to talk about your well-being, that it is important to talk about your well-being in the long run.
That's really helpful. I'm also curious, we've also heard the term of moral distress. Dr. Hlabaki, Dr. McFarland, how do you differentiate burnout from that concept of moral distress? How are they different? Are they interrelated? Are they completely independent?
So I'll take the first stab, I guess. So actually, the research says that either moral distress precedes burnout, or that they can co-occur. It sort of depends on what literature you're looking at. So moral distress, the individual is in an environment where they know what is the moral action, the right thing to do, but because of the environmental constraints around, they are unable to perform that duty. And certainly, if there's an extended period of moral distress, certainly that can lead or be correlated to burnout. And the research is very clear. There have been some initial research in hematologic malignancies. We've seen that Dr. Schoenfeld was a part of. So both very important, and especially you being an ethicist, it's incredibly important for us to recognize that phenomenon can co-occur and actually even precede burnout. So as a community, we have a responsibility to recognize the ethical implications that burnout really does bring. Danielle, I'm curious as to what's your perspective.
Yeah, great. I agree completely. I just generally would look at it as burnout's a sort of broader umbrella term, and that moral distress has both moral and distress, moral implications of certain situations. The ways in which they're similar, a lot of the moral distress, as Faye was saying, come from being in a position of where your power is undermined or your autonomy to make decisions is undermined. And obviously that is tough across the board, causes distress. And even in terms of like health inequities, you can look at like how much like locus of control you have predicts your health. I mean, so it's just, they go hand in hand. The other thing about the moral distress is, when you're making the decisions, you're less likely to be distressed about them when it's other people's decisions. So a lot of this actually comes out of the nursing literature about moral distress. But at the same time, there's the idea of moral success and moral climate, and so all things moral. So again, it's there's a lot of ethical implications to burnout, but it's more that burnout exists, the implications of burnout that leading to worse patient care, worse quality of life, and all those other bad things. Yeah, but this is really about specific situations. And as it happens with, I think, ethical situations, the more that they're discussed, brought up, different perspectives are evaluated, the moral distress can sort of recede. And so the solutions are different. That's the solution for moral distress, and for burnout it's a little bit more amorphous. That may not be exactly what you would need if you were burnt out.
Yeah, that's really interesting, because I can't think of anything that would add more to my sense of burnout than knowing the right thing to do and feeling disenfranchised from doing that. That would be really difficult and would really cause additional stress and anxiety. And so I can see how they're related. But Dr. McFarland, how do you know when burnout's starting? What are the signs? What are the symptoms? And then what happens if you don't address your burnout?
Great questions. I think we have seen burnout in other people, and it may be easier to recognize burnout in others than it is in ourselves. That's it kind of goes without saying. I would be most inclined to pay attention to those subtle automatic thoughts, if you will, that start their, as I was describing earlier. That's really the beginning of it. And looking at variations of the sort of pattern of yourself. And I mean, the definition of burnout is emotional exhaustion, cynicism, depersonalization, this idea of personal accomplishment. But all of that is kind of vague, right? And any given day, you could have a little of this, a little of that, the kind of stuff. There's a general barometer, I suppose. And I think this is one of the challenges of working with burnout is it's not going to get to zero. Where is that level that's kind of good enough? It's hard to say. So in terms of identifying when you're having burnout, I think even, as I mentioned, sort of tongue in cheek, but even talking to colleagues, having that conversation about it is how do you think I'm doing? I don't know, that might be a little too much, but, looking a little outside yourself to look at your patterns, right? Like, well, why am I showing up to work, 20 minutes late every day? What's going on? Trying to take a look at something a little deeper to those behaviors. And I think it's kind of an iterative process in that regard. Maybe change one thing here, one thing there. And so there was a second part to your question. The first was about signs and symptoms of burnout. And the second part was, what was it exactly, Todd?
What happens when you've got burnout and you don't do anything about it?
Oh, boy. Okay. Great question. If you were to ask me the same question about depression, I would tell you that the general course of depression is like 9 months. Just, hauling through it for 9 months. Don't do any therapy. Don't take any medications, and you got about a year of suffering. I don't know that that's true with burnout. I think burnout is a relational kind of concept between a worker in the workplace. And that's a way that it's different from depression, because symptom wise, they can look very similar. So the other thing would be just all of the bad consequences of other entities that are associated with burnout, namely depression, anxiety. We're talking about issues with relationships. These are your crucial support systems. We're talking about your job, your work, your calling in life being compromised. And as has been alluded to, these symptoms can start early in one's career, even in training. And that's why they are so important to address, because it's a time when we want to be putting our best foot forward, and burnout doesn't allow for that to happen. So the consequences are myriad. I mean, you name it, anything, almost anything bad, right? That's the short answer.
I really like, and it resonated with me when you mentioned, using a trusted individual as kind of a barometer, to kind of check yourself. But it also seems that having that trusted person that you can even talk about it with might be a way of preventing or supporting or addressing burnout. So I really like that idea of somebody that you can trust and check in with. So Dr. Hlebaki, how does this show up at work? What are those work-related and personal risk factors that can make us really susceptible to burnout and depression? How does our practice environment, what's its role in our risk for burnout?
Yeah. Well, first I'll speak a little bit historically what research has identified as what are some of the individual and the organizational risk factors. So originally and historically, a lot of research and studies had confirmed that it was the single, the unmarried, mostly female, junior clinician, the very type A personality, very dedicated to one's job, not knowing when to set sort of boundaries, very much dedicated to patient care, potentially the community oncology oncologists, for example, that was the person that most prone and at risk for burnout. But also now we have identified that it affects actually everybody at every point in time in their career. So although females may present with exhaustion, males present with a great deal of cynicism. So those kind of earlier research, it has really changed. And the COVID pandemic in particular, we'll have to see years from now, but what's the research that's in its infancy says that the sense of loneliness, the fact that the oncologist really misses their colleagues, their patients, even the family members, that isolation that they've had to undergo as a result of caring for potentially COVID positive patients, that is quite challenging individually. But more so, we really need to focus on the organizational risk factors. And historically, it's been those, of course, long hours working with seriously ill patients, increased administration time, the limited autonomy and independence, and lack of control over the daily responsibilities that a lot of clinicians, and the increase in the EMR, that really takes away from that clinical encounter. Why did so many of us become clinicians? Because we loved our interactions with patients, but yet now we're more beholden to the EMR and to the computer and doing all this administrative work. So certainly research has shown that almost more now recently, within just even the past 5 years, that the organization and that environment, that culture, it's important to change. It's important. Burnout is reflective of the practice health. You won't have a burnout physician if the practice is supportive in a way. Now, and that's not to beat up at all on administration or leadership. I work with tons of leaders that want to help their colleagues. They just don't know how to. So it's important to encourage both the individual clinician as well as for the system to change. So important to optimize our clinical environment, really to change that culture, the infrastructure, the resources, the EHR, scribes, for example, have been used in some practices as a support, and really reducing the stigma associated with burnout and any mental health issues that may arise as a result of unaddressed burnout. And so many colleagues are just frightened to report that they're having an issue, that they might be judged, that they have to report it to their state boards. We really, really have to come together as a community to optimize oncology care and optimize well-being for the oncology clinician.
Yeah, absolutely. I mean, this is a great tie-in to the environment of care that we work in, the systems that we work in. So I'm very curious, Dr. Lavasani, are there any burnout prevention strategies that your institution or your practice is using?
Yes, we have a well-being committee at my practice that meets once a month. We have access to an external psychiatrist, counselor, and also an internal psychiatrist. She also sits on the well-being committee. All physicians, there are multiple activities that we can attend, like virtual winter parties. And there are also Zumba and yoga classes over Zoom that twice a week that we can participate. And there are also support sessions using mindfulness to recognize, reduce stress. And we have also annual medical staff survey about burnout and stress.
It's great to hear that your practice and institution is taking some steps to support their providers. That's great. Well, this has been a terrific conversation. I've really enjoyed it. I feel that I've learned a lot from all of you. So thank you, Dr. Lavasani. Thank you, Dr. Hlebaki. Thank you, Dr. McFarland, for your engagement and conversation today. Unfortunately, that is all the time we have. But we thank all of our listeners today for listening to this episode of the ASCO e-learning podcast. To keep up to date with the latest episodes, please click to subscribe and let us know what you think about the podcast. Leave us a review or email us at elearning@asco.org. Thanks so much, everybody.
Thank you for listening to this week's episode of the ASCO e-learning weekly podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive E-Learning Center at elearning.asco.org.